Hello, everyone. I would like to invite all of you to our Edmund Kim Distinguished Lecture Series. And today, Professor Edmund Kim will deliver us about imaging of thromboembolic diseases. And if you have any questions or comments in between the lecture, you can give us some comment in the chat. Then we can actually we can deal with your questions or comments at resting time or after the lecture. And please welcome Professor Edmund Kim.
Thank you, Professor Sir. Hello, everybody. Good morning in your time. Today, I'm going to talk about thromboembolic diseases. And next week, I'm going to talk about imaging of infection. As you might know, that the thromboembolic disease and infections are two major clinical problems because most of us and most people died of either thromboembolic disease or infection or both. So if you find any better way to diagnose and treat those conditions better than what we can do now, you'll be rich and famous. And also, if you find some way to prevent these problems, then you'll be even better than what you anticipate. So I'm going to review imaging of thromboembolic disease. First, I'm going to basically review what we are dealing with. As you know, blood clot is accumulation of red cell inside the blood vessel, as you see on this diagram. Okay. So let's clarify the terminology. The thrombus is a vascular clot. It could be arterial or venous. Arterial thrombus has a less platelet, and the venous thrombus is more likely with fibrin. And when the thrombus travels through, we call emboli, etc. So embolus is a small clot, but it could be a blood clot or air or fat to pass the blood vessel. When this is a blood clot, air, fat obstructing tiny vessels, could be embolism. Now, most thromboembolic diseases are related to atherosclerosis. Atherosclerosis is a fat atheroma, fat plaque in arterial wall. And so arterial wall becomes thick and hard. That's called arteriosclerosis. Now, the terminology of a thrombotic microangiopathy is now become very hot topic because almost all diseases are related to microangiopathy. And that is produce a certain hemolytic anemia, renal dysfunction, thrombocytopenia. Now we have some new drug which deactivate C5 and complement those are the factors inducing microangiopathy. And also you are using D-dimer in diagnosing pulmonary emboli. D-dimer is a product from the fibrin degradation. D-dimer has a very high sensitivity, but very low specificity, just like many other diagnostic blood test or even imaging. So There are lots of false positives by old age, pregnancy, operation, trauma, liver diseases, rheumatoid arthritis, inflammation, and cancer. False negatives are sampling of early or very late or insufficient, or certainly anticoagulation therapy. So again, arterial versus venous thrombosis is basically related to the platelet versus a fibrin component in that blood clot. You can see acute coronary syndrome, ischemic stroke, or some limb claudication or ischemia are related to arterial thrombosis. But deep venous thrombosis and pulmonary embolisms are related to venous thrombosis. So here again, blood clot accumulating, and with a platelet, that's a relatively acute process, and that eventually burst arterial wall and travel. And the venous is mostly chronic type. It's fibrin, and then a red cell mixed together makes a venous thrombosis. So this wall become very thick, hard, as I mentioned earlier. So thromboembolic disease is a major problem in every country, because we are living longer and longer. So this thromboembolic disease has been a third cause of death, probably more than that nowadays. And the deep vein thrombosis contribute to the pulmonary emboli, but this deep vein thrombosis, I'll mention detail later on, is often caused by operation, trauma, and such cancer, and stroke, pregnancy, and certain fibrin is mixed with the red cell. So we have some ultrasound, radionuclide, and now maybe more specific immunoscintigraphy diagnosing antibodies against the fibrin. And so we often need a differentiation of new versus old blood clot that's deep vein thrombosis. So the new one is related to platelet, as I say, more likely arterial type. The old one is more organized fibrins. So depending on what element we are labeling and dealing, we can make a more specific diagnosis. And by current treatment, heparin, warfarin, or acute, some melting agent of thrombose things, there's still 5 to 10% bleeding complication. And in pulmonary embolism, some chronic pulmonary hypertension is a major clinical problem nowadays. So again, it's increasing worldwide, quite frequent, particularly in elderly patients, because the wall of our vessel become less elastic with the aging process. And so, and also maybe a high cholesterol diet, less maybe exercise, etc., contribute this problem we'll talk about. So it's aging is another major factor for deep vein thrombosis or pulmonary emboli. And in female and male, both are similar in instance. So it's multifactorial risk. And this thromboembolic process can affect any organ or tissues. So there are three sort of stages of coagulation process. Initially, platelet attached to endothelial or vascular endothelium. And then the fibrin released from platelet, fibrin. And then it was initially damaged, make some kind of a hole, but the fibrin sort of sealed the damaged endothelium. And then a red cell attach and makes a polymer type, sort of mass or nodule, and is a process of coagulation. So in pathophysiology, okay, initially injury, certain vascular injury, and then lots of factors are shown involved in the processes from platelet and thrombin and fibrin and blood clot. There's a lot of factors involved. So in this kind of things, initially certain factors initiate after platelet accumulated, activated, and then a certain factor, this 7, 9 is initiated and then amplified with the other factors, 8, 9, and then makes prothrombin converted to thrombin, fibrinogen become fibrin, and then clot formation. So we'll see more of this. So there are three sort of pathways involved: intrinsic, extrinsic, and some common so-called final pathways here. So clinically, we measure PT, that's called prothrombin time. That is prothrombin time is basically related to extrinsic, sort of extrinsic factors involving this process. So we measure prothrombin time for more likely extrinsic, but partial thromboplastic time, that's a PTT. PTT, that's the time for blood clot using intrinsic and the common pathway factors. So clinically, the prothrombin time using this extrinsic factor is about 10 to 12 seconds. But the partial thromboplastin time utilizing intrinsic and common pathway factors is about 30 to 45 seconds. And so if we measure PTT, if PTT is lower than a normal range, 30 to 45 seconds, there is a risk of a blood clot thromboembolic disease. If this PTT time is prolonged, that indicating heparin infusion or sepsis, or all these factors malfunctioning or decrease, and also some of these factors produce antibody against them. So if these intrinsic or common pathway factors are not working, then PTT, partial thromboplastin time, will be raised. That's what we clinically measured. And in our we call INR, that's international normalized ratio of prothrombin time. So that's usually calculated by the prothrombin time we measure divided by a normal range from international normal range. So that's usually 2 to 3, less than 3. So this is, there have been some, with this, some kind of phospholipid plays a role in those converting factors. Fibrinogen become fibrin, that's a final stage. Prothrombin becomes thrombin, that's most important. So from usually factor 7, and then there's finally factor 13. So there has been some modification, but the basic principles are same. So again, we have a certain drugs inhibiting process. Antithrombin is one way, antithrombin. But there's also now further here, active protein C here, protein C inhibit V converted to VA, and there's A converted to 8A. So there's a new therapy, protein C plus thrombomodulin, to make a better sort of treatment with less bleeding side effects. Okay, as I mentioned, okay, extrinsic, all these factors measured by this prothrombin time or international normal ratio. And but intrinsic or common pathway together, the partial thromboplastin time we measured clinically. Okay, so what factors or conditions influencing coagulation? Okay, so hypercoagulation has been associated with malignancy because cancer patients don't usually move much. So a stasis seems to be major cause of this problem, just like a pregnancy. But this estrogen we mentioned is a very useful for a lot of ladies' metabolic process, but estrogen also causes a certain cancer as well as this blood clot. So certain, it all relates to dosage, and so patient conditions. Certainly trauma, surgery, those are all damage to the vascular wall. And then certain inflammatory bowel disease and nephrotic syndrome, kidney, and sepsis, and thrombophilia, and that's more like a genetic disease. So that's hypercoagulation conditions. But as I mentioned earlier, the trauma to the vascular wall by surgery, trauma, all this caster, particularly in caster, indwelling caster. In cancer patient, everybody receive certain venous or arterial casters. So they are all in risk situation of thromboembolic disease. And then certain coagulation, circulatory problem producing stasis. So stasis is a major causative factor of coagulation process. Yes, so it's a paralyzed patient or heart trouble or certain varicose veins or obstruction. Those are the all common clinical problems. So, what happened to this hypercoagulability? And this shows antithrombin deficiency. Certain this gene factors certainly influence. And then protein C or S deficiency. So usually vitamin K dependent, this anticoagulation system has a problem by mutation or this protein C resistance. So this kind of things has been known, and we have a sort of new treatment with that kind of information. So again, age, old age, certainly smoker, obesity contribute. And the previous history of blood clot, antiphospholipid syndrome, that's also, because this lipid is contributing in certain factor 7 and factor 13. And then certainly all the history of stroke, heart disease, and there's certain broken bone that will make an immobilization. Cancer, some region, cancer has a pan-neoplastic syndrome, which makes a lots of diseases. And certain hormones like estrogen, that kind of things. So the thrombin itself on endothelial surface has a anticoagulation activity. Yeah. So endothelial wall, and then you have a certain precoagulant activity generating a coagulant, that's a thrombin, and then this thrombin bind to thrombomodulin, and that's anticoagulation, and activating protein C. So protein C also bind to protein S, this kind of. So if there's a mutation in protein C or S, and if there's a mutation of factor 5, and mutation in thrombosis, that will all cause problems. Certainly inflammation caused the shedding of this thrombomodulin. And so inflammation, as I mentioned many times in this lecture, triggered all kinds of diseases. And so is a plasmin is an anticoagulant plasmin. So plasmin activator has been used for very acute stroke. If anyone develops stroke and then move to that patient to the emergency room in any major medical center, within usually 4-6 hours, by using this plasmin activator, and they can melt that clot before they become fibrin, a clot. So there's a lot of new drug, alpha-2 antiplasmin, affecting this kind of things. So this plasminogen converted plasmin, and it makes so in this plasmin is sort of enzyme activation makes this conversion. And so there are some drugs on each steps in trial period. So this is one of drug, Alteplase, that's a dissolving fibrin. But this, we have to use this one in acute stage. Acute means usually within 4-6 hours. So this drug is a recombinant tissue plasminogen activator. That's actually protease. Protease, this enzyme, sort of melt a certain membrane, and the serine protease is certain melting this blood clot. So if we label this kind of drug and then image serially, then we know how this works better in vivo. So there's a plasminogen activator initiate fibrinolysis, sort of melting fibrin. And so some are very beneficial. But if some report certain cases can be beneficial even within 24 hours. Most cases in the literature usually 4-6 hours. So we don't know yet exactly. So many factors involving this synthesis of a plasminogen activator, and the obesity, smoking, birth control are against the synthesis of. So that's the problem. So thrombosis is, as I mentioned earlier, atherosclerotic processes are usually cause. But atherosclerosis leads to thrombosis, and then thrombosis leads to atherosclerosis. So it's a vice versa. And the key problem is that when we see thrombosis on imaging, if there's a rupture, ready to rupture, that's a problem. So we have to deal with this thrombosis before the plaque ruptures. And the reason is that the site of vascular injury is very turbulent in flow, so that's the site of plaque development. So imaging may be helpful to demonstrate such a risky plaque ready for ruptures. And there's a plasminogen activator inhibitor. That's a new therapeutic agent inhibitor. Is synthesized in the vascular smooth muscle and fat cells. And then some has a elevated level of this inhibitor, and the certain inflammation, obesity, they do have these inhibitors. But this level also associated with the thromboembolic diseases. Okay, there are many enzymes also working in this converting plasminogen converted to plasmin. So these kind of enzymes have been, particularly urokinase, streptokinase has been used for a long time. So these are certainly working, but it's a risk for bleeding things. So now this kind of new enzymes in this last process, fibrinogen to fibrin, this kind of has been in clinical trials. So again, now we look at a thrombus, and there's a lot of initially in a fibrin, there's a deposit with the red cell, so that's blood color, and obstructing here. And then initially fibrinolysis, particularly this plasminogen activator, and then here, and then this cytokine things produce cytokine, and some later it's broken here. So a lot of cells are involved. You can see here, immune cells and other also cells are involved here together. So within a week, thrombus is mainly this kind of a polymorph nuclear and some growth factor and some cytokine here. Later, after a week, monocyte usually, and certainly some cytokine IL-13, and certainly collagen accumulated. So there are some new tools to just mechanically remove this thing. This is called Silica Nano motor. This they put, see they put this tool here, and then maybe urokinase release rapidly here. So it's a melting. And then a slow release of heparin for preventing further coagulation process. So this kind of thing, therapy, this new therapy, mechanical things can be obtained, but in this acute process. So nanoparticle has been sort of used to to make some kind of therapeutic effect. So is in affecting, activating platelet agonist. It's yeah, it's still in more likely research, but nanoparticles can be useful for diagnosis and therapy. In nuclear medicine literature, there are many radiopharmaceuticals, as you see on this right side. Many agents have been utilized to image thrombosis. And the endothelial sort of a certain selectin and VCAM, this kind of some protein can be imaged with this PET or a technetium agent here. And so a lot of inflammatory cells can be targeted by FDG non-specific agent, certain technetium labeled cytokine, chemokine, and folate receptor, and mannose receptor, okay, and a certain liposome, and a certain even somatostatin receptor. Because in the clot, there are so many cells together, and certain inflammatory peptide here, and choline is a fatty metabolic phagocytosis nanoparticle, phagocytosis. And then a proteolysis, a protease has been labeled with the technetium, and certain angiogenetic component, neoangiogens, integrin are labeled then. And then hypoxia, that's a redox, that's a hypoxic agent, misonidazole. And certain calcification, when the fibrous caps form and ready for rupture, there's a calcification. The calcification can be shown by this bone scan agent. So here we have angiogenetic agent, glycolytic agent, and hypoxic agent, and certain immune cell agent, and somatostatin receptor agent, and some this mineralization that makes a calcium microcalcification. So that's by bone scan agent. So, okay, so aging process makes all calcification, myocardial infarction, cerebral infarction, certain gangrenes, and aneurysm with calcification. So it's a calcification, and so how much fibrous plaque, how much fat, and so a lot of things we certainly look at it, but the precise quantitative measurement of certain component is still not easy. Now, as you probably know, Vero pathologist triad, that was proposed almost 170 years ago, and that's the alteration in the vascular wall, blood flow, and property of blood. So thrombosis is unbalanced thrombogenic factors and protective mechanisms. So there's always injury started and platelet accumulated that attaches to the cell wall and some inflammatory process, and then makes finally fibrin and red cell thrombosis. So here, lymphocyte, monocyte, it's activated platelet and platelet plug, and then certain this kind of are selectin working together in endothelium, and that makes a blood clot. So there's a key component is stasis, immobilization, and then vascular wall damage. So that will lose loss of antithrombotic mechanism. So inflammation makes a contributory factor, and certain blood clotting factor problem, usually often congenital things, hemoglobinopathy, etc. So again, stasis is a major issue. endothelial damage, certainly by trauma, but also smoking, hypertension, certainly catheterization, that's a common problem. And then this sort of more like a congenital certain factor problem, particularly protein C deficiency, and then acquired cancer, chemotherapy. Chemotherapy itself damaged vascular endothelial wall, and certain hormones, estrogen, pregnancy, obesity, all contribute. So inflammation activate endothelial wall. That's enhanced tissue. There's coagulation and that also enhance the endothelial adhesion molecule. So the inflammation is a key contributing factor. So again, abnormal vascular wall makes endothelial dysfunction that can be due to hypoxia, certain hormonal things, or some congenital things like a protein C deficiency, and abnormal slow flow, particularly in the turbulent flow site at the bifurcation of vessels. So aneurysm usually occurs same in the area of bifurcation. And in venous stasis by immobilization, hypoxia, etc. And then rupture the plaque induce prothrombotic factors. So enhance the platelet reactivity and a certain tissue factor bearing microparticles. So compare with the normal, and if they quantitate, and you can see certain this factor 5 will laden, that's highest risk. And then, so this all factor 5 is laden, very high risk. Certain other things also showed some risk compared to normal. Oral contraceptives, that's 4 times more than normal risk. But other factor 5, prothrombin, certain gene makes a much higher risk. So in the tumor, what happened? Tumor, we said, produce a lot of factors. It's certain growth factor, but a lot of factors, enzymes, and then that will also contributing this kind of factor 10 converted to factor 10A. And also tumor has produced lots of microparticle like exosome. This also contributes some coagulation activation. So tumor secreted a lot of thrombin, growth factor, other things together. Certainly this inhibitor is make a fibrinolysis sort of a process, and this cancer certainly makes a problem, plus chemotherapy add a lot of this problems with the inflammatory reaction things. So platelet in normal usually 150 to 450,000 in the blood serum, new this tumor cell activate the platelet, and the lectin is lectin also elevated, and it's stimulating a microRNA that's a sort of a non-coding RNA without making protein, but it associated with cancer-associated fibroblasts. So fibroblasts, as I mentioned the other time, this pancreatic cancer has lots of fibroblasts. So that's why recently our PET imaging using radiolabeled fibroblasts seems to be the best cancer imaging agent at this time. So we are hoping to use that in clinics very soon. And certain growth factors produced, and then makes our tissue, and also the stromal cells with the fatty tissue. So this all together contribute to angiogenesis, or endothelial cells proliferating, fibroblasts, and pericyte vascular smooth, or angiogenesis. New vessel formation for proliferation, growth of the cancer. So there's, again, a microparticle from monocyte, platelet, endothelial cells. Be a procoagulant. Increase the selecting certain proteins and activating certain clotting factor, factor 7, and makes eventually fibrin, and then thrombosis become amplified. So there's a particle. So in obstetric patient with the venous thrombosis, and then you have to group high risk group, intermediate, then low risk, and then high risk, low molecular weight heparin still used, and then some this younger patient, if the risk is very low, just a mobilization, and then some enough hydration, and then the other, after 35 years old, and it'll be high risk, intermediate risk group, you still give low molecular weight heparin to prevent further clotting process. So if we look at a platelet function, you can see not only coagulation process, but all kind of other things relate to platelet. So all important growth factor synthesis, cytokine, chemokine, or a microRNA, that's important for new cancer therapy, and certain mitochondrial function, and estrogen function, and the hemostasis, and the also immune regulation. So infection, certain bacterial inflammation, and even neurodegenerative, Alzheimer, Parkinson, and cardiovascular. Obviously, all this related to platelet. So cancer as well, cancer metastasis, tumor killing. Yeah. So platelet is important. As I mentioned, prothrombin time usually 10 to 12 seconds, but that, if that's normalized by sort of average value, that's called international normal ratio. So 2 to 3. And there's a partial thromboplastin time. Okay, this is extrinsic factor, this intrinsic plus a major last phase of factors, usually 30 to 40 seconds. So PT over PTT ratio, sometimes measure, or just usually clinic eye and air, or just PTT. So this is a little blurring slide, but the prothrombin time is here, usually less than 13. Partial thromboplastin time, usually less than 50 seconds. The fibrinogen, hemoglobin, hematocrit, and platelet, 100 to 200, 400, sort of 10 to the 3, that's one. So it's a platelet, lower platelet, you have bleeding risk, higher, that's a hypercoagulation. And there is some interaction, just like any other disease, platelet here, neutrophil here. So a lot of this kind of gene factors are hooking together, it's related. So here on each side. So depending on which one you're gonna slice, that makes a difference. So it's in bacterial endocarditis, bacterial dissemination, that's a neutrophil extracellular trapping is increased. Okay. But and if the bacteria is in hot valve, it's decreased. So this in the condition of sepsis, the neutrophil extracellular trap is increased by organ perfusion. If the organ damage, it's a liver damage, it's decreased. And thrombin activity decreased, then this neutrophil extracellular trap is decreased. And the bacterial pneumonia, the NET is increased, and also bacterial dissemination is also increased. So sometimes this neutrophil extracellular trap measurement is useful to think about differential diagnosis. And in thrombosis, platelet adhered and then activated, and with very many of this kind of factors, genes. And so, as I said earlier, microangiopathy is now major clinical problem in every disease. So tiny vessels become obstructed by clots. So for example, in diabetes, insulin resistance certainly makes insulin resistant or insulin secretion impaired, then that microvessels are dysfunctioning, cause the retinopathy, nephropathy, all kind of depression, other things. So it's sort of a cyclic. If there's a microvascular dysfunction, it can make impaired insulin secretion and then make diabetes. If diabetes, then this microvascular dysfunction and the thing. So this is cycling. And so a diabetes itself is not the problem, but the complication like a microvascular dysfunction is a problem and also a cause of death and or morbidity, nephropathy, retinopathy, blindness, renal failure, and also some loss of leg, amputation, because of no circulation in the feet or hand, that kind of thing. So if there is a hyperglycemia and these vessels and all these important organs are not functioning, and then make angiopathy. And this will make atherosclerosis. Certain will make hypoxia. Hypoxia in also just like inflammation, hypoxia triggering every disease process. So it's all recycling. So see the just like a brain tiny in retina, arterial, venous is connected here. And then black and tiny this occlusion here by thickening of basement and the serial damage, some red cell, platelet, and the black and the leaking here, leaking. So leaking. So loss of pericyte, so that's a major problem. And this is a sort of a schematic diagram of retina. You can see a glucose comes here, glucose, and then metabolize and produce lactate. And in this also neuron, glutamine goes, lactate, this things. We mentioned, I mentioned about the glucose metabolism some time ago, and this, yes, glycolysis is actually anaerobic, but in Warburg effect, glucose make more lactic acid instead of going to pyruvate and in the mitochondria to generate energy. So this lactate this lactate is a useless compound in the body. It's toxic. And so this toxic makes it damaging all the tissues or this vascular walls. And so the normal, we have a thin wall things, endothelial function with this genes, NF-kappa B, NOT, POP, that's it. But if there's a hypoglycemia, and we can see impaired vascular sort of damage. So and the diabetic microangiopathy, vascular wall, capillary or endothelial wall is very thick, hard, and some blood clot. Block eventually arterial makes a malfunctioning. So in endothelium, there is NF-kappa B activation. This gene is important in developing cancer as well as inflammation. So there is an increased reactive oxygen species, and certainly a very harmful metabolite including lactic acid, and also increase the lipid POX-based product. And then in immune cells, macrophage, all kind of cytokine increase, and protein C, that's also produced. And the smooth muscle, increase proliferation, so wall become thickened, and this kind of chondroitin sulfate proteoglycans, collagen is increased. So the glycation, this aging process, similar to inflammation or cancer, all this contributing. So, but the gene is mainly NF-kappa B. So it will make inflammation, arterial stiffness, and then reactive oxygen species make endothelial dysfunction, other things. So other immune cells also malfunctioning. So this all together makes advanced sort of similar to the other one, with just a pathway, and the continuous is triggering and tissue damage. And certainly hypertension, heart failure, coronary arterial disease, stroke can occur together with this. And so if we decrease all these contributing factors, that will make less arterial stiffness and longer, sort of a survival. So again, a coagulation process, inflammatory process, share the certain genes and some factors together. So how we balance things, that is a key issue. So if it's not balanced, go this way, coagulation, this one, inflammation, by all kind of factors, cytokines. So another complicated, now when you, nowadays many patients, particularly cancer patient, died of disseminated intravascular thrombosis. That's the common last sort of a diagnosis. When the patient develops sepsis, that's usually gram-negative, and then they call superbacteria, which is not responding to common broad-spectrum antibiotics. So that's a mutated gram-negative bacteria, usually Klebsiella, E. coli, that kind of things. Those, the abscess makes intravascular thrombosis, as you see on this, many factors influencing. So it's finally, and this HMGB group B makes a significant contribution and makes a necrosis. But other factors are, so sepsis generate endotoxin and makes all this blood clot together. So that's a common major clinical problem in sort of a ICU or ICU usually patient with this sepsis and eventually died of disseminated intravascular thrombosis. So we have a lot of tests clinically. That's INR, as I said, that's a prothrombin time, international ratio, hypercoagulability, is usually high, but hypo pattern that's going into disseminated thrombosis. And it's high. And D-dimer, I mentioned, this is a product of fibrin, very high here. And then platelet, obviously, very low platelet in this condition. Slowly low, very low. And in early stage of disseminated coagulation, and the fibrinogen is high, fibrinogen. And then, so that's what it is. So in vascular plaque, initially inflammation, that time FDG, PET scan show, macrophage usually accumulate, macrophage. So microcalcification formed enough, then PET, the bone scan agent, like a sodium fluoride, or even MDP show. And certainly CT show high density calcification, microcalcification. So that they're indicating a plaque burden ready for rupture. So that's so you can see here, we see often there's a calcification in the wall. So some correlating with sodium fluoride PET scan, and it's quantification show some relationship. So we can be here, and this anterior descending coronary artery here, calcification. So let's see. Okay, it's already 1 hour past. We'll have a 10-minute break, and then I'll finish up defense thrombosis, and then move on to pulmonary emboli as a last discussion. So I will start in 10 minutes. So again, if there's any question, comment, or any suggestion, write down on your sheet or email, whatever. All right. As you see on this slide, deep vein thrombosis usually occur in the lower leg or lower thigh. This is a venous valve here, venous valve to prevent regurgitation. Flow should flow continuously towards the heart in venous system. So there is a valve. So this kind of area will have a lower flow rate because of this mechanical disturbance. So that will make some stasis. So, and then here in the endothelial cell, there is some gap between cells, and then platelet aggregate in between here. And the certainly collagen and intrinsically activated as well. So again, activation of coagulation is related to inflammation. A lot of these factors involve protein C, again, decrease protein C, and the endothelial damages occur, and then it makes hypoxia and cytokine release, and internalize thrombomodeling, and then thromboactivating inhibitor release. So there's, again, just like everything else in our body, there's always required homeostasis. If it were too much certain factors of clotting, and that's clotting. And the more and the bleeding, it should be balanced. So again, lots of factors, but basic thing is with all venous damage, everything, and that will make a stasis. And then inflammation, triggering more all this coagulation factors, makes thrombosis, and eventually fibrin deposited things. And certainly not only leg vessel, but myocardium, other things, you know, in the hepatic proteins like C-reactive protein we clinically use, fibrinogen, all this albumin, everything is checked. And so on the images, there's a CT, you can see contrast going into the portal vein, and there's a filling defect here. So that's easily can see portal venous thrombosis. And then also this reconstructed coronary images, you can see IVC, inferior vena cava, is completely thrombosed here. Yeah. So usually this comes from leg vein, either right, left here, or and the you can see in contrast study, see this arterial abdominal aorta, and this inferior vena cava, and so completely defect, no feeling of contrast, and the venous thrombosis is progressed upward. So if you follow all this kind of transaxial images, you can see. But reconstruction, coronary sagittal images can easily show whole vascular thrombosis. So in the female, there are lots of causes of pelvic pain, certain physiologic, inflammatory, and certain genital urinary, all kind of cystic lesions, fibroid, other things, gastrointestinal, all disease, and obviously some lower lumbar disc, sacral, other things. So many differential diagnoses you have to consider. And one of them is called pelvic congestion syndrome. Pelvic congestion syndrome is non-cyclic, and then usually more than 6 months. And this is often, we don't usually think about, clinicians don't think about these things, but in the female, you always have to think about this related dilatation of gonadal and pelvic veins, particularly premenopausal multiparous ladies. And it's, as you know, in the female pelvic veins are sort of a networking. So left ovarian vein connected to left renal vein, left side renal vein. Right side directly connected to inferior vena cava. So, okay, you can see here left ovarian vein, left renal vein. Right side ovarian vein goes to inferior vena cava. So if there's an obstruction, you have a lot of collaterals. So normally renal vein should be open like this. But some reason, if it's skewed here, it's skewed, renal vein skewed, then you see the ovarian or testicular veins is very engorged here, because it's not flowing there. So it's once you black here, it's all done. Yeah. So venogram usually show. So if there's a blockage here, the collaterals goes to here. Yeah. So ovarian varicosity is often frequent after pregnancy. Everything is by pressure dilatation, but it slowly recover in usually 3 months. But If it's not, that's a problem, often make a thrombosis there. So there's a vascular vein incompetence. So it's a problem is sort of a reflux in the sort of a network, and the exact cause besides the obstruction is unclear. Some hormonal factors like estradiol, vasoconstriction, and then this induces uterine vascular enlargement. And that also makes a dilatation of ovarian uterine veins. So there are several unusual name causes: May-Turner syndrome, Nutcracker syndrome, Budd-Chiari syndrome, etc. So it's May-Turner syndrome is quite frequent. On the left side, the lower venous thrombosis, and then exact cause is unknown, but some kind of right iliac artery overlying to venous wall damage, obstruction, etc. Nutcracker is left renal vein, sort of a compression, like I showed that case. It's rare, but sometimes it requires surgery. So venogram is gold standard to show obstruction of iliac vein, gonadal vein, etc. So this goes this left renal vein connected, left sort of ovarian vein obstruction, all this. So it's diagnosis easy, but clinician has to think about it more often. And then varicosity can be asymptomatic, and but chronic pelvic pain should include this kind of pelvic venous varicosity. And then also in the male, penile erection dysfunction, erectile dysfunction is also caused by this kind of vascular thrombosis. And the penile erection is a sort of a parasympathetic relaxation of muscles and dilatation of arterial. So the arterial flow erect is about 4 or 5 times more. But if there is some obstruction of that the penile sort of vessels, there's lots of people in NIH study, lots of people, about 25% at age 65, and the 20 million American men. And the cause importance of lots of vascular, but other causes, but vascular cause is curable if we diagnose. And the internal iliac artery has a lot of branches: gluteal, iliac, lumbar, lateral, sacral. Anterior trunk has the inferior gluteal, obturator, all this that goes into pelvis. This goes into buttock. So, and the male pelvic, this whole thing, there's a pudendal vein. This is a pudendal artery, penile vein. And here, this is the penis here, it's branches. And this blockage here makes or kind of that erectile dysfunction. So this is an internal pudendal artery opening here. But in this case, this side is all, you can see all the branch. There's nothing here. So it's a blockage, occlusion, right side. So there's a surgically microsurgery can open up or reconnect it. And so that's why you have to consider the things. And deep vein thrombosis, the ultrasound, Doppler ultrasound can show easily, okay, some echogenic thrombus. So we can see But CT easily show, yes. And then there's called thromboelastography. So certain technique can show clot initiation and then maximum clot formation, and then some sort of a fibrinolysis, and the normal range certain time is and then here this varicose vein type things, and then easily it should go on, go on, but if you have a certain there's a blood clot obstructing and makes swelling, working, and then more problem is just developing tumor emboli. So there's a lot of techniques, basically anatomical study, but certain specific radio-labeled anti-platelet, anti-fibrin is more specific for thrombus, so peptide, etc. So technetium, indium labels, those things have been used. So here, anti-fibrin, anti-platelet. These are more, anti-platelet is more acute arterial, anti-fibrin more chronic and sort of a venous. So synthetic, this technetium is a thrombus, acute. So in this nuclear venogram, injecting either MAA technetium or sulfur colloid. If you want to diagnose tumor emboli, MAA is better, but the dynamics, sulfur colloid, it's easier because everything goes to the liver, spleen. Here, if you inject into antecubital vein, the cephalic bacilli. So here comes one is a cephalic bacilli. And then lower down, there's a left innominate vein come down, but you can see collaterals up and down. This is a sort of a left side superior vena cava. The right side superior vena cava here. So normally you have to see only one line comes here, innominate and superior vena cava empty into the right heart. Obstruction, collaterals and supraclavicular, and the left sort of a supra vena cava, superior vena cava, all collateral. So there's a hemodynamically significant obstruction. Now ultrasound, MRCT show clot, but they cannot tell hemodynamically obstructing or not. Certainly they can guess with a 90%. In this kind of flow, if there's obstruction of 50%, there's nothing, no clinical value, no significant. But if there's obstruction more than usually 70, 80, there is a clinical problem with the swelling, pain, etc. But once you see this kind of collaterals, there's a hemodynamically significant obstruction. Here, this anatomy, all kind of, but when you inject here, it's a cephalic, bacillic, some brachial things, bacillic 2 runs, the joint subclavian. And in the lower leg, okay, there's a superficial gray saphenous vein here, deep vein, deep femoral vein, deep vein here, deep. And the deep vein has an anterior, posterior, tibial, and peroneal. So this superficial one usually runs medially here. Deep one inside the middle and concave. This one is bowing this way, but this one is concave. So by shape, you know where the, so you have to put the tourniquet tightly to block superficial to show deep channels here. Iliac, femoral, iliac. So here, marker on the symphysis pubis. Okay, here ilia, common ilia, external ilia. The femora already two. One, this is a superficial. So this is superficial great saphenous. This is a deep vein, deep vein. There's a popliteal deep femoral vein here, femoral, that's deep. So if you put the tourniquet tightly, you're not supposed to do this superficial. But here, you may see some collaterals if there's a partial blockage here. And here you can see left side popliteal, but here you have some anterior posterior tibial and peroneal. And here, obviously, it goes femoral, stuck here, and then goes here. So there's something blocking here, just above this. And you carry on, see. Obviously, here, this right side femoral, ilia, and inferior vena cava. Left side, lots of activity here, crossing pelvis. And so there's a blockage here, here, here. All these are collaterals. And this femoral has all collaterals here, the popliteal. Okay, here again is collaterals here, and the obstruction is here. So once you have obstruction down here, you can have obstruction in many proximal portions. You cannot pinpoint down. If you cannot inject MA particle or sulfur down in the pedal vein, we can use red cell in the antecubital vein, and that will show activity in the major vessels, so arterial, venous. But looking here, you can, unlike a right side, so lots of collaterals here. So you can at least suspect some obstruction here, obstructing collaterals in the proximal thigh. And here, the angiovenogram, so MR venogram. You don't have to inject anything. MR show big defect here, right side, the common iliac. The left side are common, and maybe external iliac collaterals. MR. MR venogram can show leg here, swing here. This is a superficial grace, superficial. This is a deep. You have all this collateral. You don't see any deep here on the right. This is a superficial chain. Knee is right here. So this superficial. This is a deep femoral. Yeah, you don't see here. This all collaterals, right side. So here again, with the red cell, it's not easy, but any asymmetry, you have to look at. If there's a asymmetry or lots of collaterals, or you can suspect, but that's not the best. Okay, again, all swelling, varicose vein, I show you. And then we have lots of imaging agents in the past, particularly anti-D-dimer, okay, labeled with technetium, and it's called peptide epsitide. This is an anti-platelet antibody, labeled technetium. So if we inject and then take an immediate dynamic picture, you can evaluate the mechanical obstruction of venous system or arterial system. And then after you wait 1 hour, all the activity should be washed out from normal vascular system. But if there's any retaining activity remaining, that's the relatively arterial acute blood clot, because this platelet accumulation. This was very good in my personal experience, but the company was a small company. Before they FDA approved, but right after approval, the company was bankrupted, disappeared. So this kind of problem is very unfortunate for nuclear medicine people. That was very useful for this kind of thromboembolic disease. Now, this is the Indian platelet. So this is certainly acute arterial platelet, acute. So this require the TPA rather than heparin to melt down some this acute blood clot. This fibrin, technetium labeled, show activity. Again, some accumulation is fibrin, or this fibrin substance. And this is again antibody against the platelet or fibrin. So there's a last report about at least 85% accuracy. And this P280 peptide for active platelet here active platelet require sort of a new therapy. And this D-dimer has been also labeled the antibody. They show this. This platelet aggregate sort of a product, a fibrin product. So treatment, certainly anticoagulation therapy, heparin, low molecular heparin has a less bleeding side effect, and anti-aggregate by aspirin mostly. Thrombolytic therapy required for early sort of arterial, that's a kinase, streptokinase things. And then certain elastic bandage and that kind of things. Anti-inflammatory therapy. So pharmacologic, low molecular heparin, vitamin K antagonist. That's usual. So it's a mechanical, they can put the IVC filter and some, as I said, certain mechanical sort of removal. Okay, it's, prevention is the most important. And certainly good exercise, avoid any immobilization, that's important. Vitamin E is very helpful in these things. In this, and ginger, pepper, and some cider, and turmeric, all these things. Okay, the arterial disease, it's peripheral arterial disease, we have a thallium in the past, but the Indian platelet is a platelet accumulation, and certain this MAA, microsphere, non-particle red cell, the thallium distribution is relative to perfusion, tissue perfusion. And so this kind of things, resting here and then exercise things, some asymmetry, you can see. It's an old study, no one seems to use this anymore. But now we talk about pulmonary emboli. Pulmonary emboli mostly comes from venous thrombosis in the leg. It just traveling to, eventually it goes to the lung and stuck in the lung, a small vessel, capillary or pre-terminal arterial things. And it's also, this is one of the still cause of death. Many patients died of, particularly cancer patient, or because they do have all catheter, and so they have all the time some blood clot, but no one knows how much blood clot killed the patient. And the 10% patient die within the first hour. So by the time we see patient in the emergency room, have a lung scan, the chance for the death is very, very rare. They died before or they arrive in emergency room or arrive in the nuclear medicine department. As long as we put oxygen, then there is no pulmonary infarction. Pulmonary arterial does not deliver any oxygen, so soon after patient develops shortness of breath, chest pain, put a ventilator for the oxygen, then they will not die. Not die. But still, we have to exercise for quick diagnosis and the treatment. I'm sure you still do some lung scan, but unlike in my old days, many nuclear medicine departments seem to have much less lung scan these days because of CT. But as I mentioned earlier, diagnosing asymptomatic pulmonary emboli remains clinical challenge. No one knows what's the best way. Because if we use heparin things, you create unnecessary long-term morbidity and eventually complication. And and also current problem is chronic pulmonary hypertension. Okay, without therapy. So that will cause a lot of other lung problem. Here, pathophysiology, right heart overloading, left heart failure, some atherosclerosis because of less surfactant, and hypoxia, and this bronchial constriction, and okay, chronic pulmonary hypertension require also a lot of factorial things. Okay, and then increase permeability with many factors, and then inflammation can trigger things. So clinically, we can have ultrasound, venogram for venous thrombosis, and then CT usually done first, and then if there's a question, things, and then nuclear medicine lung scan and pulmonary angiogram for maybe and the symptoms are related to either bronchial. See, our body trying to maintain VQ ratio. So if Q is down, and V has to be down also. So that causes bronchial obstruction. So shortness of breath things. But that's only acute process. But most of the other cases, bronchial obstruction. So V is down, then Q is down. That lasts for a long time. And as I said, pulmonary artery does not deliver any oxygen. Bronchial artery delivers oxygen. So even you block a big pulmonary arterial segment, as long as you provide oxygen, there will be no problem. Okay, so PO2 measurement usually required in the emergency room. Most often, internists think PO2 low, just lowering PO2 they immediately think of pulmonary emboli. That's the wrong thing. If the PO2 is down, that's more likely bronchial disease. PO2 100 can have a pulmonary emboli in about 5 to 10%. But most common PO2 level is about 60 to 70% in proven pulmonary emboli. But as I say, even 100 PO2 can have a pulmonary emboli. So in the diagnose, obtain the D-dimer, okay, CT angio things, and CT venogram together. And then if there's some problem things, pulmonary lung scan. Now here, problem is, okay, if there's a major pulmonary arterial filling defect here, that's usually no problem. But now see here is a major pulmonary arterial trunk on the right side, and that require certainly therapy. But there are many small blood clots in small vessels. But this one is not that small, but tiny, incidental, particularly. When I was in MD Anderson, almost every case on CT for lung metastasis show blood clot, every case. So because they all are on a central line, the catheter on venous system, so there's always blood clot, and that move to lungs and block this terminal arterial or capillary. No symptom, incident. What do we do? So if we, many surgeons are reluctant to heparinize because of bleeding. And so when they die, autopsy show massive pulmonary emboli. And the lawyers sue the doctor that they didn't treat pulmonary emboli in advance. But doctors are saying that at the time, CT showed such a tiny pulmonary emboli, there was no symptom. So therapy might give more complications. So there's a continuous argument. No one knows which one is better. So that's why nuclear medicine has a well-known statistical value, high probability, low probability, etc. And I will mention soon. So this kind of sort of a haziness or alveolar density. A patient has underlying a lot of fibrotic change. These are small vessels clotted, small vessel, incidental, small vessel filling defect on a contrast enhanced study. No symptom, what do you do? If you heparinize, a patient has the recent surgery, that's a trouble. And once you heparinize, it has to be continued at least 6 months. So that's a problem. And a lot of small blood clot, this kind of. And this COVID recently show ground glass. COVID show lower lobe, periphery ground glass. And then small, maybe this kind of infarct or small. And small vessels are blocked here. But patient has a pneumonic symptoms. So intrapulmonary hemophagocytosis, they call microhemorrhage. Microhemorrhage by the inflammation. That's inflammation damage the vascular wall and that makes a hemorrhage. That may be a hemorrhage. And COVID-19 pneumonia. So small pulmonary emboli is a key issue, big problem. Overdiagnosis is a problem nowadays by CT. because CT resolution is 1 millimeter. Anything greater than 1 millimeter size and nodule defect show on the current CT, that caused the problem. So, as I said, we still don't know what to do. Yeah, this kind of microangiopathy, again, in the alveoli, there's a gas exchange and bronchus and capillaries here, and there's a lot of certain factorial things like hypertension, thromboemboli, makes the clot blocking and the vascular fibrosis, etc. And then this kind of things makes a chronic pulmonary hypertension. So how we handle, okay, if you wanna treat, divide the high risk, low risk, and pulmonary scan, and with certain D-dimer, that kind of things. And so, in these days with the COVID-19 and the CTA first, and then just looking forward. If it's normal, that's it. But in abnormal, then do the lung scan to make a high-low probability, and then manage the patient. Now, as you know, the lower lobe is bigger than upper, so more ventilation, more perfusion side in the lower lobe. But ratio is up higher in apex, the other way around. And so it's a xenon study, in and out, washed out, uniform activity, breathe in, out, gone. MA particle, that's a particle 10 to 100 micron. Okay, that will block 1 out of usually 1,500 terminal arterial, not the capillary. So that's why it's so safe. It shows uniform activity, outlining good margin. So this is called stripe sign, good margin. In the oblique, posterior, inferior, good margin. This is, so any defect along this wedge defect along this margin should be considered. So here is a multiple defect, multiple bilateral segmental, more than 2, that's called high probability. High means greater than 80%. So that requires treatment with normal ventilation, normal ventilation. But you always have to also consider other possibility, certainly in this kind of multiple bilateral unusual, but unilateral certain lobar segmental VQ mismatch could be due to congenital hypoplasia, HYPO, hypoplasia of the certain pulmonary arterial segment. Then only perfusions can show defect, but normal ventilation. Yeah, okay, so so always to think about intrinsic as well as extrinsic compression of pulmonary arterial segment when you are dealing with. So particularly in patients with cancer, lung cancer as well as metastasis, it can obstructing pulmonary arterial segment extrinsically, okay? That will not cause ventilatory abnormality, only pulmonary perfusion abnormality. And certainly bronchial lesion will show obstruction and retention on this ventilatory study. So now there's a PioPad, all that things. No one seems to use this kind of criteria, but everybody agree more than 2 VQ mismatch high greater than 80%. And everything else, if you don't see anything, okay, no, then very low means less than 1%. There is no way you can detect microemboli, pulmonary emboli. And then that caused by either blood clot or fat or air. Because so small, the nuclear lung image cannot show. So don't ever say no pulmonary emboli, just a very low. I usually put a number. When you say high probability, how high? The clinician don't understand. So always put down greater than 80%. Very low means less than 1%. You put a number here. I never use intermediate, indeterminate. That's a useless terminology, useless. Most scans, most means 70, 80%, in that category. So nuclear lung scan has been useless because of that report. So using your knowledge of clinical information, patient information, and the other imaging like a chest X-ray or CT, and you can make it high or very low, nothing here, then it's useful. But if you put down here, you describe defect and intermediate or indeterminate, that's useless. So high, low, that's it. High greater than 2 mismatched, that's it. And non-segmental or chest X-ray, normal, all that kind of thing. Stripe sign, there's a very low. And large pleural effusion, attenuating things, so you can't talk about, but still called very low. Because very few cases, exceptional case, show pulmonary emboli in that condition. So here, so that's why you need the multiple oblique, lateral, whatever, if you don't have a SPECT system. So you have a linear defect along the fissure. That's due to fluid or chronic fibrosis along the this fissure. So if you know the anatomy and things, and then certain pleural effusion things, attenuating things, it's all very low probability. So certain defect is a right side holds this side. So this ventilation there, and perfusion normal, nothing here. And so VQ, this ratio, whatever things here. And so any large perfusion defect is unusual for hematological pulmonary emboli. Mostly a bronchial narrowing by cancer that block a whole lobar segment. A ventilation study usually show a retention by xenon gas, and perfusion is just a decrease because of VQ ratio. But in this case, you can see the other normal ventilation and the abnormal perfusion. That's a proven pulmonary emboli. That's a large, but it's not common find. The common find is a multiple bilateral. That's a high probability. So VQ mismatch, a lot of differential diagnosis, particularly lung cancer, extrinsic compression of pulmonary arterial segment, and by HILA or mediastinal adenopathy, and certainly congenital hypoplasia, this kind of thing, post-radiation, etc. So you have to consider. So here you have multiple bilateral perfusion defect, okay, and then just looking, and the ventilation normal, mismatch, multiple, that's high probability. And then nowadays we use SPECT CT to locate more precisely the defect, and then looking CT for any, the vascular defects. So here we have an nodular mass, here. So this kind of a SPEC CT is much more easier to interpret study and quantitate. So okay, the D-dimer is a fibrin degradation product. Okay, so it's used higher sensitivity but very low specificity, as I mentioned earlier. So that's why it's useful to check. Positive, high sensitivity, high. And but increasing with age and then pregnancy, and the radio-labeled D-dimer is useful for acute, relatively arterial. So that require sort of a thrombolytic agent rather than heparin. So this kind of should be more useful in clinical practice. But all the companies, small companies, develop and bankrupted before they reach the FDA or clinical trials. That's the dilemma we have. So this MAA false positives, that's a clump, all things, you know. So this kind of, if you, because this MAA is a fat, unlike human microsphere, that's synthetic. But this one natural, so it's accumulated. If you have a difficult to find the vein, hit the vein with the bleeding things, they attach the clot and show this kind of blood clot particles. Now, always check to see any kidney activity. Once your kidney, you have to look at the brain. So there is right to left, either cardiac or pulmonary shunt. Pulmonary shunt usually occur in patients with chronic cirrhosis, a VA hospital or some kind of alcoholics. They do have a pulmonary shunt. So if a pulmonary shunt is a lot more than a certain minimal amount, you can make a stroke. There have been 4 cases reported. So if there's any blue baby, for example, lips are blue, that means a cardiac shunt, then you have to use less than 1 millicurie technetium MAA and inject very slowly, little by little. That's the only way you can avoid problem. Okay, and the but always show and then calculate how much you are seeing kidney and brain out of injected dose. So there's a calculation or the things. If there's a brain show the normal range is 5% something, is a variable. So anything greater than 5, you have to consider significant. Certain a surgical evaluation of a lung function based on lung perfusion scan or ventilation scan for resectability, not resectability, operability. Resectability is no problem. Nowadays, a thoracic surgeon remove anything they want without much problem. But if patient has an underlying poor lung function, the operability is very limited. So using FEV1, that's a pulmonary function test, you normally greater than 2 liters. So minimum is should be 1 liter or more. So calculating the resection and the remaining of the lung, and then see how much the patient might have a FEV1 after surgery, you can make an operability issue. So this is one of example, okay? So if there's a lung cancer, pneumonectomy is the best, but if that is not feasible by the lower FEV1, certain lobectomy. And then you have to calculate the rest of lung times FEV1, and then it should be make a greater than at least 1 liter per second. So this kind of things. You can divide into half or 3 zone and calculating. And then, so you can help thoracic surgeon to give operability. So again, suspected pulmonary emboli, you start with CT, D-dimer, and then make a groups of probability, and then manage the patient and have a short follow-up. So a lot of agents have been used for pulmonary ventilation as well as a perfusion, now diffusion. Okay, this kind of diffuse abnormality, either ventilation, perfusion, that's often related to chronic obstructive lung disease. In this case, FEV1 is barely above at 1. That's not good. So they cannot remove any lung tissue with this kind of patient. Okay, it's the technique gas for ventilatory study. You have some ventilation, nothing here, nothing on the left side. Okay, when you see one lobe things, it's mostly related to lung cancer obstructing left main bronchus. So bronchus is shut down, then V is down, nothing. So adenocarcinoma usually centrally. Location is usually squamous cell. Adeno is usually periphery. That's somehow unusual. Okay, and then sometimes, okay, okay, this seems to be a combination of lung and the liver spleen scan together. And now with the SPEG, you can have a 3-dimensional sort of images, so you can locate the pulmonary abnormality better, precisely. And the xenon gas wash in, wash out, and then perfusion study show. I don't know. Okay, here MAH show bilateral multiple perfusion defect ventilation show no particular retention after 3 minutes, and 1 minute, 1 to 3 minutes. After breathing and equilibrium, 1 minute, and then 1 minute, 1 minute, 1 minute, wash out. By 3 minutes, everything should be gone in normal. Multiple, this classical VQ mismatched. Okay, and the, in this case, okay, one side doesn't show. So this is a big loba or some. Yeah, this side shown ventilation show nothing, and then the perfusion show a little bit, but it's diffused, no focal abnormality. So it's a lot more ventilatory problem, and then you certainly have to check any fluid attenuation. The patient lying down and pleural effusion attenuating all things. That's the first thing you have to check with the chest X-ray thing. And otherwise, it's this kind of large one, always thinking about blocking major pulmonary bronchial segment rather than arterial segment. And certainly, In this case, ventilation good and no perfusion. Chest X-ray doesn't show, but there is a mass here. So that block is so well, but this is we have to look at the CT. For certain vascular anomaly can also make this one, as I mentioned. So you have to solve either this mass blocking or some extrinsically pulmonary arterial segment. That's most likely. Yeah, it's a diffuse sort of some non-uniform. But this right, this lower, you don't see any particular, but just attenuation is large heart, but ventilation okay. Perfusion doesn't show any segmental perfusion. This are all the slide, but still ventilation normal, but there's a defect here, and the bilateral stuff. That's called high probability. Okay, so I will not waste the time. And so tomography is helpful nowadays. And so in medical treatment, usually heparin to prevent further thromboembolic process. But in acute, unstable patient, you have to consider thrombolytic agent. That's helpful within usually 4-6 hours, but maximum 24 hours. And certainly anticoagulant therapy, low molecular weight heparin has a less side effect. And then usually warfarin, other things, as you see, all this factor 10 inhibitor and certain thrombin inhibitor has been tested. A vitamin K antagonist that to synthesize protein CS, that's kind of thing. So has been recently used for warfarin, still used, but side effect is still a problem. Yeah. So vitamin K is a reverser. So this kind of new agent to inhibit factor 10A has been used for, and then direct thrombin inhibitor also used for. Antiplatelet therapy. So all aspirin, other things, dipridamol, adenosine reuptake inhibitors, this kind of things also used for. Platelet transfusion has been thrombolytic for acute, usually acute arterial. And here, right carotid here, and on this treatment, it's open up here. And the FTG accumulating macrophage in inflammatory vascular wall show here. And the wall is very thick here. And the kappa 64, this agent also showed a ApoE positive sort of thrombus carotid in animal study. Certain immune cell macrophage has been studied, and this kind of endarterectomy, this kappa 64 labeled this PET MRI together show some accumulation in that plaque with hemorrhage. This or this clot T1 show high, signal, that means it's acute sort of hemorrhage things. So it's a monocyte, it's a chemokine receptor labeled with PET agent, kappa, show some uptake here in the animal model. So ruptured abdominal aortic aneurysm can be predicted by this chemokine labeled PET isotope here. So it's a nanoparticle CT contrast also has been tested in the abdominal aortic aneurysm, and that could be used for diagnosis and maybe eventually for therapy. And so SPECT CT system use a protease activity, and then this particular RIM1 agent labeled technetium show sort of a protease activity and some this kind of vascular abnormality, ruptured or things here surrounded different cells. So I'll stop here. And so in summary, we still have a major problem dealing with deep vein thrombosis, particularly acute arterial, for the diagnosis and therapy. So reviving technetium-labeled anti-platelet antibody seems to be important. If we detect, we can give a thrombolytic agent for the therapy. And then that will also make a good treatment for pulmonary emboli, acute pulmonary emboli. So think about it. I hope our basic scientists work on that, and then have some clinical trials. But in the meantime, we have to educate our clinicians for the utilization of nuclear venogram as an indirect method of significant, hemodynamically significant venous obstruction, and also hemodynamically significant pulmonary emboli for the treatment. After they check with contrast CT, if contrast CT doesn't show anything, then stop. But if contrast CT show small pulmonary emboli, and then D-dimer is just slightly elevated, then you need the nuclear medicine lung scan to group high or very low probability of pulmonary emboli. That's a very useful, helpful to prevent chronic pulmonary hypertension. That's a major clinical problem nowadays with unnecessary therapy and morbidity. So I will stop here, and next week I will give you a talk more important, imaging of infection or inflammation. Particularly nowadays, we have a coronavirus infection, and we need a more and specific agent for infection versus inflammation. And that also helpful to separate inflammatory reaction of cancer from pure infection or inflammation. All right, I thank you very much. Again, if you have any question, comment or criticism, write down on the paper or email. And I hope you keep good health with all coronavirus worldwide. Okay, there is a question. Can the mismatch defect become match defect with the progression of disease? Yes, yes. If you treat a patient, then pulmonary emboli become resolved. How fast? Usually within a week or maximum 2 weeks. After 2 weeks, you don't need to repeat lung scan. So within 2 weeks, if you diagnose with some doubt, then it's worth to repeat within 2 weeks. Then pulmonary emboli it will be changed either by physiologic flow phenomena, because arterial flow breakdown is a pulmonary thrombosis, or with the therapy heparin. So it will be changed. Defect become less defect or no defect. All right, thank you. Oh, now there's a, we diagnose lots of different thrombosis, pulmonary embolism. What added benefit spexity? Well, spexity is easier to interpret by precise location. You see, as you know, pulmonary segment on the right lung is 10. The left side is 8. And it all overlying. So planar imaging, all overlaps a small pulmonary emboli obscure because of scattering activity. But if you slice, you eliminate scattering activity. So you can detect a smaller defect. That's the advantage. And then match with standardized ventilation perfusion easily. But planar, depending on how you rotate the patient, how you position, makes it somewhat difficulty. Oh, there is also, I will talk to you next week. If patient got a COVID infection, any effect of high activity technetium MAA to the virus? That's a very interesting question, but I'll mention those things next week. All right, thank you.